بسم الله الرحمن الرحيم والصلاة والسلام على سيدنا محمد خير الخلق أجمعين. معلش على الانتربشن اللي حصل مع المحاضرة بتاعتي. أنا بشكر أساتذتي الكرام وبشكر الجمع الكريم وبشكر الدعوة الكريمة من أساتذتي. إن شاء الله أنا هتكلم على case presentation trying to complete the missing issue. 15 years old girl from positive consanguinity marriage presented with recurrent generalized tonic and clonic convulsion. She had also recurrent oral ulceration, dental problem, delayed growth. She had also a past history of prolonged diarrhea that was unresponsive treatment to medication since the age of 5 years. At the age of 7, she had a pain and paresthesia and muscle cramps. She had at that time candidiasis that spread all over his legs and her trunk. And now she seeks the medical advice for the primary amenorrhea with incomplete pubertal development. Her examination revealed the BMI 19 that had an alopecia, had a hyperpigmentation of mucous membrane of the mouth and both palm. Skin on arm and legs has a whitish patch, not biting nail. She had a keratopathy. The hair fundus is normal. She had a dental enamel hypoplasia. Her abdomen, chest, and heart, no abnormality detected. Her neck had a goiter, and her Tanner stage is 2. Her hemoglobin, her CBC revealed that she had an anemia. Her fasting blood glucose level is 39 millimole and have ST and LT is normal and creatinine is within normal. Her thyroid band revealed primary hypothyroidism. Her calcium is decreased and her magnesium, and you have and also decreased the BTH, which revealed primary hypoparathyroidism. Her beta cortisol is low, and after ACTH stimulation, she is positive for adrenal insufficiency. LH and FSH is increased and have an estradiol is decreased. Her CT brain revealed intracranial calcification, and her CT chest have an bronchiectasis. Her ultrasound have a small uterus and ovaries. This is the picture that revealed my investigation. We have an also cerebral calcification. We have an also a biting nail. We have a bronchiectasis, and then have an keratopathy and pigmentation in her mouth. So this my case presentation is about the autoimmune polyendocrine syndrome type 1. This autoimmune polyendocrine syndrome type 1 is a misnomer that not all patients have multiple endocrinal disorders. They have also non-endocrinal disorder. This autoimmune polyendocrine syndrome, a rare syndrome. We have non-endocrine and non-endocrinal disorder. According to Nafeld and Blizzard classification, we have a 4 type of autoimmune polyendocrine syndrome. We have an ABS type 1, an ABS type 2, an ABS type 3, and ABS type 4. My case presentation, the chronic mucocutaneous candidiasis, hypoparathyroidism, and adrenal insufficiency. Type 2 autoimmune adrenal insufficiency and thyroid disorder, and or type 1 diabetes. ABS 3, you have an autoimmune thyroid disease and other autoimmune disease after exclusion, the autoimmune, the endocrinal manifestation that occur in ABS type 1 and 2. We have also an ABS type 4, 2 or more organ-specific autoimmune disease, which that doesn't fall in type 1 or 2 or 3. We have also another classification, ABS type 1 and type 2 and 3, and have an heterogenic polyendocrinopathy due to the use of the immunoregulatory agent that used in the tumor blockade of the immunoregulatory checkpoint. The ABS type 1, I have another names. We have an autoimmune polyendocrineopathy, candidiasis, ectodermal dystrophy. We have the multiple endocrinal deficiency, autoimmune candidiasis syndrome, juvenile autoimmune polyendocrineopathy, and they have a Whitaker syndrome. The ABS is a very rare manifestation, a very rare disease. It usually affected about 500 patients worldwide. It's most common in the Iranian Jewish and Sardinian and Finlanders. The autoimmune polyendocrine syndrome is inherited as autosomal recessive pattern. What is about the genetic background of the autoimmune polyendocrine syndrome type 1? We have a gene called autoimmune regulatory gene. This gene is present in the short chromosome of 21 chromosome, and this gene is responsible for synthesis of a protein called the autoimmune regulatory protein. This autoimmune regulatory protein helps the T cell to distinguish from the self-antigen and the non-self antigen. We have the T cell here, T cell that's usually present in the thymic gland and the bone marrow and will transfer to the thymus gland. We have most of the T cells that they have self-antigen and non-self antigen. according to the autoimmune regulatory protein and gene, it will destruct all the T cells that they have the self-antigen. So a small amount will transfer to the periphery of the thymic gland, and with this process is called the central tolerance. If there is a failure of this central tolerance, all the T cells that have self-antigen will move to the periphery and will transfer to autoimmune process, and the autoimmune polyendocrinal syndrome will occur. What about the mucocutaneous candidiasis and why it occurs in autoimmune polyendocrinal syndrome type 1? Most of us are protected against candida because we have a cytokines from the T cells. If I have an antibodies against this cytokine interleukin 17 or A or F or 22, it will be a candida in this presentation. What about the manifestation of the ABS type 1? We have the endocrine manifestation and the non-endocrinal manifestation. The non-endocrinal manifestation about the candida, which is usually present in 100% in the patient, and we have after that we have the nail dystrophy and we have the nail hypoplasia, and after that we have a vitiligo and alopecia. The endocrinal manifestation, we have a hypoparathyroidism and the adrenal failure, type 1 diabetes, and primary hypogonadism. The first question, what are the sequence of clinical manifestation of ABS type 1? What comes first, the non-endocrinal manifestation or the endocrinal manifestation? I'll proceed.
اولا يعني سعيد اني موجود في السيشن القويه دي، بس يعني بالنسبه لليانج جنريشن لو حد بيفكر ياخد اندوكراين ياخد، ما يخافش. الاندوكراين موست ستريت فورورد، الحالات دي يعني حالات فيري رير، فيعني ما حدش ينخض منها لان كلها معظمها رير. الحاجه الثانيه انا سعيد طبعا بان اجاور الاستاذ العزيز مكانا ومقاما نتعلم منه كلنا. الحاله اللي بتقدمها الدكتوره ميادة الحقيقه اسهل شويه من الحالتين الاولانيين اللي هم هايبر فانكشن والريبليزم. هنا بنتكلم على الاندوكراينال ديفيشنسي اكتر، سواء بقى بالنسبه للاندوكراينال او نون اندوكراينال. الترتيب بتاعهم يا دكتوره ميادة يجي اكتر يعني السؤال اللي انت عرضاه.
تمام. الترتيب بتاعه the non-endocrinal manifestation usually precede the endocrinal manifestation and usually start at the age of 5 years with mucocutaneous candidiasis, or maybe affected also the vitiligo, alopecia, and hepatitis may occur at the ABS. There is a non-endocrinal manifestation usually precede the endocrinal manifestation. We have the biting nail, we have the candida infection in the tongue and the skin, we have the keratopathy, and we have here an alopecia and vitiligo and the skin candidiasis. The endocrinal manifestation usually characterized by 3 clinical: mucocutaneous, hypoparathyroidism, and the adrenal feature. We have 2 of 3 clinical features are required to make the diagnosis of ABS type 1. The hypoparathyroidism is the first endocrinal disease to develop during the course of ABS1. بتوصل النسبة بتاعتها لحوالي 70 to 93% of cases. It varies according to the age، بس ممكن الفيميل بيشنت هم اللي بيبقوا affected أكتر من الميل. ولو الادرينال insufficiency is come first in endocrinopathy, susceptibility to hypoparathyroidism appears to be reduced. What about the primary adrenal failure? It may occur in 60-100% with the peak incidence about 12 years of age. We should aware about the hypocorticolism and the hypoadrenalism may appear years apart. We have the hypergonadotrophic hypogonadism. This female in my presentation, I have a hypergonadotrophic hypogonadism appear in 12 to 60% of patients, with prevalence more common in female than male due to the blood testis barrier usually protect the leading cell from autoimmune attack. We have also pubertal development affection, and my case have Turner stage 2. We have also in my case we have anemia. We have in this patient atrophic gastritis and pernicious anemia. We have intestinal dysfunction and malabsorption. prevalence بتاعتها varies حوالي من 15 ل 22%. البيشنت ممكن تيجي manifestation سواء chronic constipation او chronic diarrhea، بس should ناخد نقطة في البراكتيكال بقى بتاعتنا، لأن ممكن الهايبوكالسيميا تكوز هي نفسها تكوز mal absorption، والmal absorption يكوز more and more hypocalcemia وندخل في vicious circle. الاوتو اميون ثايرويد ديس اوردر ممكن يحصل هايبوثايروديزم في حوالي 30% من الحالات، او اوتو اميون ثايرودايتس بس الهايبر ثايروديزم بتبقى رير. تايب 1 دايابيتس ممكن تحصل في 18% من الحالات، وممكن يبقى في اسوشيشن ان يبقى في بيتيوتري فيرير وفي مالتيبل اندوكراينال ديفيشنسيز موجوده. الاوتو اميون هاباتيتس ممكن يبقى فيه مايلد افكشن اور سيفير افكشن يوصل للليفر فيلير. ساعات في بعض الحالات يعني لقوا فيها سبلين بليزيا او هايبوبليزيا، وممكن تحصل تبقى البيشنت مور برون اكتر ان يحصل لها لا قدر الله انفكشن او ريكورنت انفكشن. الرينال ديزيز ممكن تحصل وتبقى مايلد اور ايفن سيفير توصل لرينال فيلير. والبلمونري ديزيز سبيشالي ان ماي برزنتيشن الكيس بتاعتي ما كانش فيها هو يعني